based on sound public health guidance and not on political pursuit of a scapegoat. Science must have a voice at the table, whether it's regarding treatments for the current and future pandemics, climate change, or other issues of public concern. We must include science in decision-making. Ignoring science is dangerous and a disservice to the American public. Mr. Chairman, I yield back.
Thank you, Mr. McNerney. Next, Mr. Bilirakis.
Thank you, Mr. Chairman. I appreciate it. And I want to thank the presenters for their testimony today and all the work you do on behalf of our constituents. Dr. Fauci and Dr. Hahn, in the scientific community's COVID-19 response, we've seen unprecedented scientific collaborations and research information sharing at a pace unlike anything before in history. Clinical trials are approved in record time while laser focus remains intent on patient safety. Regulators and drug manufacturers are learning from each other, from joining together in the critical fight against COVID-19. In line with that innovation is the COVID-19 Evidence Accelerator, which is a public-private partnership initiative launched by the Reagan-Udall Foundation for the FDA in collaboration with Friends of Cancer Research to advance understanding of COVID-19 through focus on analysis of real-world diagnostic and clinical data. Question, do you believe these scientific collaborations will lead to lasting changes in how we innovate for drugs and vaccines? How will the innovation changes affect research into diseases like ALS and Alzheimer's disease? Dr. Fauci, if you, okay, all right. Commissioner Hahn.
Congressman, thank you for highlighting this really important endeavor and partnership with the Reagan-Udall Foundation and Friends of Cancer Research. This effort is an attempt to really accelerate, as the name implies, the use of real-world evidence in our decision-making from a development and a research point of view. A couple of points I'd like to make, sir, and I do thank you. One is we have to be really careful that we do this in a robust and careful way, because the gold standard remains in clinical trials, randomized clinical trials. That's important that we understand that level of evidence. However, in a rapidly moving situation like we have now with COVID-19, where we make decisions based on the data that's available to us at the time, having additional data afterward as those decisions play out, as we gather evidence about how tests work in the real world, about how treatments are administered, very pragmatic data that allow us to then go back and revisit the decision. To me, there's nothing wrong with that. That's actually a really good thing. As the doctors in the room know, when you're taking care of a patient, you get more data, you bring that back to the table. In fact, you must incorporate that in your decision making. So I think this is a great opportunity. I'd love to see us do more of it, as I mentioned earlier when asked that question, and would love to continue the conversation with Congress.
Very good. Dr. Fauci, would you like to respond?
Yeah, I totally agree. I think that what Dr. Hahn has mentioned is something that spills over into what we do at NIH and NIAID, is the clinical trial process, which is really the gold standard of those types of decisions.
Very good. Thank you. Next question is for Dr. Redfield. Has CDC coordinated with agencies such as the Administration on Community Living to improve efforts to protect the elderly? What steps has CDC taken to foster increased collaboration between the public health sector and aging services sector to meet the needs of older adults during this pandemic?
Thank you, Congressman.
Thank you.
CDC has a long-established relationship with the ACL to continue to work on health and well-being, particularly the elderly, but also people with disabilities. We work together in trying to cross-clear information from other agencies and the materials. We also, CDC's reached out to, obviously, AARP, helped to provide tools for older adults that we can get out and take advantage of their distribution. And we'll continue to do that. Obviously, it's a critical group. It was highlighted in terms of the morbidity and mortality of this particular pandemic, as you know. So again, I think we'll continue to cross-collaborate with the ACL and try to help facilitate their mission.
Excellent. Next question, again, Dr. Redfield. Given the fact that we continue to learn about the virus in real time, how often is CDC updating its testing guidelines?
Well, it is intermittent. We recently posted our updated testing guidelines last Friday, and I know as we've gotten some feedback from the states, there's an interim re-posting that's going to come to clarify a few issues this week, probably. And then on top of that basic guideline, we are posting specific guidelines for specific situations. So we did infrastructure, critical infrastructure, we did nursing homes, we did medical. This week, I suspect we're going to do K through 12 and higher universities. And then I suspect shortly thereafter, we're going to do non-critical infrastructure businesses. So we are trying to add specific testing guidelines to specific situations. And obviously, when there's new science and new situations, we update them in that setting. But I think you'll see that there's going to be a series of targeted testing guidelines for unique situations that will be posted over the next several weeks.
Very good. I appreciate that. I yield back, Mr. Chairman. Thank you.
Thank you. Next member is the gentleman from Vermont, Mr. Welch. Unmute, please.
Thank you very much. Thank you very much, Mr. Chairman and Ranking Member Walden, and thank the witnesses for your patience and for your extraordinarily good work. I think it's fair to say that not a single member of this committee, Republican or Democrat, as of December last year, or even January or February, had any notion that there was this emerging threat from the coronavirus. But on the other hand, my understanding is that public health officials always anticipate, and there are two things that are essential to be ready. One is preparation, and two is communication. I want to ask a few questions about preparation. My understanding is that the National Security Council had a playbook for early response to high consequence emerging infectious diseases. And that indicated that we should, in preparation, move swiftly to fully detect outbreaks, procure PPE, secure supplemental funding, use the Defense Production Act. Are any of the witnesses aware of that report having been followed as in 2019 or January or February of 2020? Just a yes or no? It sounds like the answer is no.
No, I'm not exactly sure what you're referring to. I think you're referring to a document that was put out prior to the outbreak about what the response should be. Yes. You know, if you look substantively, much of what is that was in that document actually was implemented, with the exception, as I think you're alluding to, is that the amount of stockpiled PPE and other items that were needed were not at the level that we were able to respond in as efficient way as possible.
Right. And there was a real delay in the use of the Defense Production Act. Also, there had been a White House Global Pandemic Response Team that was eliminated in May of 2018. Anyone think that that was a good decision to eliminate that? I'm not there to see your responses, but I take it the answer is no. In the travel ban that the president did implement January 31, as I understand it, that only applied to foreign nationals coming from Wuhan, but it did not include permanent residents or family members or nationalized American citizens. Did that significantly limit the benefit of that travel ban?
Thank you for the question, Mr. Congressman. This is Redfield, CDC.
Very briefly, if you would, because
those individuals as American citizens are qualified to come into America were allowed. They went into 14-day quarantine.
But the quarantine wasn't enforced, is my understanding. Let me ask a few other questions about communication. I am sure that every one of you who's very careful about your communications knows how important that is. When the president said on February 23, 2020, that the stock market is starting to look very good and the coronavirus was very much under control. If any one of you agrees with that, would you raise your hand? And on February 27th,
I'm sorry, we
President
didn't,
Trump
none of us heard
predicted
that question, the 20,
Jer-
or could you just repeat
Peter,
that?
could you repeat the question again?
What I said is that communication is extremely important, and we have before us extremely good and careful communicators, for which I thank them. On February 23, 2020, President Trump indicated that the stock market is, quote, starting to look very good, and the coronavirus is, quote, very much under control. Does anyone at the table agree with that statement? If so, raise your hand. And another statement was that
Peter, Peter, listen to me. You got to
Yeah.
give him a chance to respond because you're not here. Did you hear his question? If you don't want to respond, that's fine, but I just... Oh, I see.
Nobody raised their hand.
I'll say nobody raised their hand. Okay. Next.
All right. Well, on February 27, President Trump said that COVID-19 will disappear like a miracle. Did any of you agree with that statement by President Trump at that time? If so, raise your hand.
Okay, no hands were raised, Peter. Next.
And finally, the President Trump indicated on March 9 that COVID was comparable to the common flu. I heard your testimony, Dr. Fauci, and you're fearful about the flu making the situation worse. But do you agree that there's any comparison between COVID and the common flu? That's
You had to put your mic on, Dr. Fauci.
Sorry, it is not the common flu.
Okay, thank you. I see my time is up. I yield back.
All right, thanks a lot. Mr. Johnson of Ohio is recognized for 5 minutes.
Well, thank you, Mr. Chairman and Ranking Member Walden, and to our witnesses, especially our witnesses, for taking your critical time. The work that you're doing is so very important. Obviously, we're not out of the woods with this virus yet, so you're still on the front lines of it. You know, I want to shift gears a little bit and talk about something I don't think I've heard anybody else talk about. You know, during this COVID-19 pandemic and the associated lockdowns and distancing orders, many vulnerable Americans for the first time became isolated and in many cases too fearful or unable to get essential health care. In eastern and southeastern Ohio, where I live, and across rural America, unfortunately, this can be the reality even in normal times. A specialist could be a 3-hour-plus drive away, or a symptom could go unchecked for days because an elderly person might not have a loved one close by to drive them to their doctor. Increased use of telehealth could help alleviate this problem. Telehealth has been a priority of mine for a long time, and it's taken on a new sense of urgency with so many elderly and medically compromised people finding it potentially hazardous to leave their homes due to COVID-19. I'm really pleased that President Trump and his administration used the emergency authority that Congress gave them to remove the regulations and red tape that had previously hindered robust deployment of telehealth. And as a result, countless vulnerable Americans now have access to their doctors from the safety of their home, ensuring continuity for essential medical care. I've heard patient after patient and provider after provider who've taken advantage of these safe new services. They love the convenience of it and the immediate access to care. They tell me they don't want to go back to the way that it was before. It's time for Congress to make robust access to telehealth permanent for all Americans, especially the most vulnerable among us. So Dr. Fauci, I'd like to start with you. Do you believe that telehealth practices such as virtual doctor's visits could be an effective tool in helping to promote or protect vulnerable individuals in the event of a second wave of COVID-19 or even in a future infectious disease pandemic?
Yes, I do, sir. I believe that telemedicine is a very important component, should have been even more implemented, but as we look forward in the future, I think you're going to see a lot more of that, not only for the reasons that you bring out, given the specific situation we're in now, but for a variety of other situations. And I think Admiral Giroir has a very keen interest in this.
Thank you. I would just like to emphasize that as well, is that I think we learned tremendous lessons about the utility of telemedicine, lessons that most of us thought that would be there. But for example, just to understand the uptake, the week of January 15th, there were only 500 telehealth visits by Medicare. The week of April 15th, there was 150,000 of them. We've seen telehealth visits be instrumental in combating our burgeoning SUD issues, particularly with opioid use disorder, teleprescribing, increasing access to buprenorphine. So I think all of us with MDs behind our name understand that the whole key is getting healthcare to people where they are and not making them come to a major tertiary or quaternary center unless they really need to be there. So we're all very anxious to increase the use of telemedicine going forward.
Okay. Well, Dr. Redfield, you know, during the last several months, we've seen situations where at-risk elderly and isolated individuals have missed regular doctor appointments and preventative health screenings. As one of America's leading public health experts, can you speak briefly to the dangers to public health if patients looking to continue mental health treatment, to check in with their specialist, or even to consult with their doctor are not able to do so over an extended period of time?
Thank you very much, Congressman. I think it's important to emphasize, you know, as we did limit health care, largely the purpose was to keep certain jurisdictions from overwhelming their health systems when we were working towards the peak. Unfortunately, with health care being broadly limited across the nation, as you point out, there were real health consequences. Clearly, in individuals' mental health services, individuals' substance abuse services, but also, you know, individuals, we have a marked decline in childhood immunization. Many people miss their preventive medicine visits for mammograms or pap smears or colonoscopies. So it is really important that we get the health system back and operational, and I do think the introduction of telemedicine is a critical component, something that needs to stay as part of the innovation as we worked more and more to move from a disease-based system to a health system. So I think it's critical. We've seen an increase in suicides. We've seen an increase, obviously, in drug use disorder. It's important to get these health services back and operational in a manner in which the American public can access.
Well, thank you very much. And my time has expired, so Mr. Chairman, I yield back.
Thank you, Bill. Next is gentleman from New Mexico, Mr. Lujan. Unmute your connection there.
Thank you, Mr. Chairman. Dr. Redfield, under federal statute, the CDC is required to treat tribal epidemiology centers as public health authorities and share all data and data sets. Dr. Redfield, last week your staff indicated in writing that the data sharing issues...
Native American, I think.
What's that, Mr. Chairman?
Commenting on your artwork, I apologize.
Dr. Redfield, last week your staff indicated in writing that the data sharing issues reported in Politico were merely a miscommunication with a single tribal epidemiology center, but that isn't true. My office has confirmed that this problem goes beyond a single center, and the centers report that they have encountered problems obtaining other data sets from CDC beyond COVID-19. Dr. Redfield, do I have your commitment to work with each of the 12 tribal epidemiology centers to ensure they get access to all the data they are entitled to under law?
Yes. The initial episode that you brought up was obviously a significant miscommunication, but you are right that there is still issues to be worked out. Our team is currently working with the Tribal Epidemiology Center, and we're committed to correcting that for all tribes.
So Dr. Redfield, you could direct your staff right here and now to release that data. Is that something you're prepared to do?
I'm sorry, I didn't hear the question.
Dr. Redfield, you could direct your staff right here and now to release that data to the tribal epidemiology centers. Is that something you're prepared to do?
We're working with them as we speak. One of the keys, Congressman, is to make sure that we have secure data systems to transport the data. And that's in fact what our team finalized that. And as soon as that is finalized to maintain the security of the data, it will be transferred. I've been told that that's going to be completed hopefully this week or within the next 1 to 2 weeks for all 12 tech directors.
Thank you, Dr. Redfield, and please report to the committee when that's done. Thank you. The Trump administration failed to bring COVID-19 testing to scale in the early months of the pandemic. Even now, 5 months later, testing capacity is nowhere near where America needs it to be. On January 31st, Secretary Azar declared COVID-19 a public health emergency. 5 weeks later, on March 6th, President Trump infamously declared that, quote, anybody that needs a test can have a test. They're all set. They have them out there, close quote. Yet on the same day, fewer than 3,300 tests were completed in the United States. On April 28th, President Trump said testing in the United States would surpass 5 million per day. Admiral Gerard, yes or no, are we currently in the United States conducting 5 million tests per day?
No, we're not. We're doing about 500,000 single tests per day.
That's my understanding, about 500,000 tests. Now, nearly every leading public health expert agrees that the centerpiece of reopening the country is robust testing, tracing, and isolation strategy. One public health expert has said, quote, the lack of testing has been not only a public health catastrophe in the U.S., but is also a direct cause of our economic suffering, close quote. Admiral Gerard, we've been hearing bold proclamations and promises on increased testing for months now, and every time they've come up short. What is going to be different moving forward, and how does the United States get to the 50 million tests promised, particularly in light of the president's evident lack of concern over the need for testing?
Thank you, Congressman, but I disagree with your question. I don't believe we've come up short every time we've said something. Since March 12th, I've been very forthright about what we're going to provide, what the limitations are, what some of the constraints are, and that we're doing everything possible to increase that. Right now, we're doing about 15 million tests per month. Although we have need for more testing, our national positivity rate is about 6.5%, so we're certainly getting in the range. Right now, 6 or 7 states are above 10%. We have to really surge into those areas. When I tell you 40 to 50 million tests, that's because I know every single lab producer, what they're doing, when they're providing it, how they're going to distribute it, and how many swabs are going to be there. So the capacity will be there for 40 to 50 million tests at least in the fall, and I have that provider by provider, material by material. And hopefully it will be much greater than that when we have pooling and hopefully some of the new technologies from the NIH, from BARDA, that we can move into that realm.
Thank you, Admiral Gerard, and I appreciate your leadership and respect you very much. The one area I disagree, though, is when President Trump promised 5 million tests per day very soon on April 28th, and we're still at only 500,000 tests each day. That appears that we've fallen short. So continue to look forward to working with you, and with that, I yield back, Mr. Chairman.
Thank you, Mr. Lujan. Next, we have Mr. Long from Missouri.
Thank you, Mr. Chairman. And Dr. Hahn, there are a number of initiatives between the federal agencies and private industry to accelerate the entire process for the development, manufacture, and distribution of COVID-19 therapeutics. The administration recently established Operation Warp Speed, and FDA has set up a coronavirus treatment acceleration program, or CTAP as they call it. Could you talk about the FDA's role in the development of therapeutics under Operation Warp Speed, and how does the FDA integrate its work and its own initiatives like CTAP with Warp Speed?
Thank you, Congressman, for the question. The Approximately 10 weeks ago, FDA stood up what we call CTAP, Coronavirus Treatment Acceleration Program, as you mentioned. And that was for a variety of reasons. One is we indeed wanted to accelerate the development of therapeutics on behalf of the American people, but do it in a very robust way that looked at the science and data. We also, because we had gotten significant number of applications, and at this point our best estimate is double the normal of applications that we have during a regular time pre-COVID. Because of that, we had to prioritize applications based upon science and the highest priorities of science. So across the spectrum of our medical products, CTAP allowed us to prioritize the science and then address those applications, because what we wanted to do was make sure that we, in real time with those applications, addressed any questions that developers had. I think the other important point here is that we had people come to the FDA who had never before applied to the FDA for an application of any sort, whether it be an emergency use authorization or an IND. And so we had to really hold hands with industry, with sponsors, with academia, to try to help get through the process. I think a great example of what can be done is the work we did with NIAID to get the remdesivir protocol up and running, and the speed with which that was completed that ultimately led to an EUA. We are working with all sponsors, sir, not just Operation Warp Speed, but we are providing all sponsors, but including Operation Warp Speed, technical assistance. What are the trials that we think need to be done? What are the endpoints that need to be looked at? How can we accelerate those clinical trials in the design? And we will continue to do that as we go through this pandemic.
Okay, thank you. And Dr. Fauci, could you speak to the HHS's role as part of the Warp Speed and its efforts to accelerating manufacturing capacities and ensuring that manufacturers can invest early and aggressively in vaccine and therapeutic development?
Thank you very much for that question, a very important question, Congressman. And that was one of the things I referred to earlier on in the discussion, that as part of the process of developing the vaccines in Operation Warp Speed, that there is the employment of contracting organizations to already start scaling up the development of vaccines, particularly the first one that I mentioned that will go into a phase 3 trial in July, has already had contracted through HHS and BARDA for the production by a contracting organization of hundreds of millions of doses ultimately, the first group of which would be delivered at the end of the year and the rest in the first quarter of 2021.
Okay, yeah, thank you. I was a little confused in your opening remark. Of course, we've been here a long time today, and I can't remember exactly everything that I heard, but I was wondering about that, so thank you for clarifying. And Dr. Hahn, I'll go back to you. Looking long term, what do you think the FDA and Congress could do to promote domestic manufacturing of drug therapy?
Congressman, this is a very important issue, and I appreciate you bringing up. We have seen across the medical products that we regulate issues related to redundancy in manufacturing and our dependence, particularly in the foreign sphere, where during a public health emergency, we might have a lot of difficulty given the increased demand of having access to those supplies, both precursor products such as pharmaceutical precursors, as well as final finished form of the drugs, and PPE. So very much we've been working on our technical assistance, because manufacturers depend upon our technical assistance to help them develop the manufacturing procedures that lead to a quality product. We very much are leaning in on this. It's one of our major initiatives for advanced manufacturing, but also domestic manufacturing. It would be very good to work with Congress further on this. I think this is a particularly important lesson learned. And the more we can bring manufacturing home and provide that redundancy to the supply chain, I think the better off we'll be in the future. Thank you.
Okay, I've got a red light, so I do yield back. Thank you all.
Thank you, Billy. Mr. Tonko of New York, unmute. Mr. Tonko, are you muted?
Can you hear me?
Yep, now we can.
Can you hear me? Okay. Hey, thank you, Mr. Chairman, and thank you to our panelists for all the information exchange. Last week, while participating in a telephone town hall with my constituents, I got a simple question from Ruby in Schenectady, for which I had no good answer. She asked me straightforwardly, if the government is telling everyone to wear a mask in public, why does President Trump refuse to wear one? So, Dr. Fauci, please help us set the record straight. What does the evidence tell us about the benefits of face masks or face coverings when it comes to transmitting or contracting COVID-19?
Thank you for the question, Congressman. So, although we don't know the exact percentage, we can say very clearly that wearing a mask is definitely helpful in preventing acquisition as well as transmission. The data for your wearing a mask, and if you are inadvertently and not knowing you're infected, protecting you from infecting someone else is stronger data than the data that says you will be protected. However, everyone agrees in the public health sector that wearing of masks is beneficial. It may not be perfect. As we often say, wear it and don't let the perfect be the enemy of the good. It is always better to have a mask on than to not have a mask on, both for acquisition and for transmission.
Thank you. And I listened earlier in the hearing to my friend colleague talk about the spike in numbers in Texas, and I couldn't help but think that precautionary efforts come to prime importance. They can be defined and written, or they can be shared by example. And so I unfortunately witness as the president seems to believe he is above this evidence-based recommendation you just described and has rejected or injected rather politics into public health. Not only has he refused to be seen on camera wearing a face mask, but last week he claimed that some Americans are wearing masks as a way to signal disapproval of him. Now, I think that leadership as a form of precautionary instruction is required of the president and any of us in elected office. And we should be setting the right example. Does the president's refusal, Dr. Fauci, to wear a face covering and his efforts to politicize the wearing of face masks send the wrong message about the advice coming from public health experts like yourself and others who are at that expert table?
You know, I don't think I can comment on what the president's, the multiple factors that go into the president's not wearing a mask. Certainly, I wear a mask in public all the time, not only because I want to protect others and to protect myself, but also to set an example. So I guess that answers your question.
Yeah, and have you at any time directly advised the president to wear a mask in public? If so, what was the response that you received?
I have not directly recommended to the president to wear a mask, but I think it's very clear to anybody in the country, because I talk about it so often, of the importance of having physical distance with a mask, and if you are going to be either beyond your control or by your own choice in a crowd, that it is imperative to wear a mask at all times.
Thank you. And Dr. Redfield, let me turn to you. On April 3rd, I believe, CDC released guidance recommending the use of face masks or face coverings in public settings, such as grocery stores. And more recently, CDC issued recommendations suggesting that employees that were staffing large events be required to wear face coverings, as well as promoting their use when someone is likely to raise his or her voice, such as at a protest for racial justice or at a political rally. So what prompted the need for these recommendations, and what does the American public need to know about the use of face masks and whether and when they wear them?
Thank you very much for the question, Congressman. I want to echo the comments Dr. Fauci made. You know, our recommendations are clear. One of the most powerful weapons we have against this virus remains as it was before, and that is social distancing, face coverings, and our ability to practice rigorous hand hygiene. Clearly, when we recognized that asymptomatic transmission or pre-symptomatic transmission was significant, that's when it was clear that we wanted to recommend that all individuals wear a face covering in order to protect other individuals in case they were asymptomatically infected. We continue to recommend that. Our recent guidance on mass gatherings, we again tried to illustrate the importance of trying to maintain social distancing and to wear face coverings. And as Dr. Fauci said, in the event that you're not going to maintain that distance, it's critical that you wear a face covering.
Well, I think it's unfortunate that, like so much of the administration's response, the message coming from the White House undermines the message coming from public health experts trying to support the health of the American people. With that, I yield back, Mr. Chair, balance of my time.
Thank you, Mr. Tonko. Next is Mr. Flores from Texas.
Thank you, Mr. Chairman. I want to thank each of our witnesses for appearing today. My internet access is a little bit spotty today, so hopefully you'll be able to hear me. I want to brag on the Trump administration and the team of witnesses that are here today for the response to the SARS-CoV-2 spread. First of all, we have several new therapeutics underway. We've got several vaccines under development. We've had a huge expansion in the supply of testing materials, PPE, ventilators, the regulatory response to deal with clearing out the roadblocks that would typically impede the development of these items has been impressive. The great example is the huge expansion in telemedicine, which has happened just in the last few weeks, despite some of us trying to promote that for years. Dr. Fauci made a pretty pointed statement earlier in this hearing, talking about the reason that things are different region by region. And I'd like to talk a little bit about the responses that were done region by region. So here are some state level statistics on COVID-19 as of yesterday. New York State has 6% of the population, but it has 22% of the total U.S. deaths. Michigan has 3% of the U.S. population, but it has about 5% of the total U.S. deaths. If you look at my home state of Texas, we have 9% of the population, but only 2% of the deaths. Now, again, these are all spot values as of yesterday. Of the top 7 states that represent 60% of the deaths, all of those are led by Democratic governors. When you look at the cases, number of deaths, New York State's fatality rate is 6% and Michigan's is 9%, whereas Texas is 3%. So what concerns me are the stark differences in fatality rates in some states' percentage of deaths compared to their percents of the population. It's obvious that some governors made big mistakes, but we're not hearing much about that today in addressing the spread of SARS-CoV-2. It's interesting that while those governors were complaining about President Trump, they were ignoring their own populations. So specifically, I think we ought to talk about our elderly at-risk population who contracted COVID-19. And let's start with these stats. In Michigan, 1,947 patients in long-term care facilities died from COVID-19. In New York, that number was 6,200. In Florida, that number is only 1,637. And this is despite the fact that Florida has a long-term care population that is far higher than both Michigan's and New York's. In Michigan, state officials declined a proposal to use new, vacant, unlicensed facilities to house patients who tested positive for COVID-19. Instead, Michigan put those patients in a nursing homes with other uninfected patients. And as we've heard previously in this hearing, in New York, the health department ordered nursing homes and rehab centers to accept COVID-19 patients who were discharged from hospitals. This led to more than 4,500 patients who tested positive for COVID-19 being put back in long-term care facilities. Now compare these policies to Florida, where state officials set up isolation centers that focused on treating patients with COVID-19. So my questions for Dr. Fauci and Dr. Redfield are as follows. As I noted, there have been fewer deaths reported in Florida's long-term care facilities compared to either Michigan's or New York's, despite the long-term care population of Florida being significantly higher. So can you talk specifically about these approaches to elderly care and whether putting COVID-19 positive patients in the nursing homes with non-infected patients with good policy and worthy decisions in the best interest of our seniors? So Dr. Fauci.
Well, obviously, if you put someone who is a potentially infected patient into a nursing home, there's a risk of there being spread. I think you gave a lot of data and a lot of situations in which there really was a moving target and whether or not there really was a facility to put individuals in. So I really feel uncomfortable in commenting about that because I was having trouble following each and every one of the data points that you were given. But Bob, do you have any further insight into that one?
Thank you very much, Congressman. Two points. First, and we're working to try to understand the multivariance, as you have pointed out, that at least on the cases, there has been differential mortality both in different jurisdictions as well as within the long-term care facilities in different jurisdictions, and really looking at the multi-factors to see that if they are controlled for, whether there's any difference. And that we really don't know at this point, but we are looking at it.
I want to ask you and Dr. Fauci a simple question. Which state had a better approach to dealing with elderly patients, Florida or New York? Dr. Fauci.
He wants to know which state had the...
I don't think I'm in a position to evaluate that. That is not in my purview of anything that I'm responsible for.
I would just say that clearly, Congressman, if you look at, as I said before, consequences and impact, for me, consequences and impact is obviously morbidity and mortality. And as you pointed out, that the mortality rates in nursing homes were clearly better in the Florida than opposed to New York, but the causation is what I'm not willing to speculate on, and without doing controlling for the different variables that we have individuals with the same extent of comorbidities in those two nursing home settings. So I think that investigation will be complete, and we'll get an understanding of why there is differential mortality in nursing homes, as well as why there's differential mortality in different jurisdictions, as you pointed out.
Thank you, Mr. Flores. Thank you.
I ask you to provide that information supplementally. Thank you. I yield back.
Now we go to Iowa. Mr. Loebsack. Unmute.
All right. I should be unmuted. Am I unmuted?
Yep, you're good.
Okay, thank you. Thank you, Chairman Pallone and Ranking Member Walden for this important hearing today. And I want to thank all these witnesses for their expert testimony. I know it's been a tough several months here for you folks trying to lead the way through this. I had hoped also that Administrator Verma would be here today, willing to join the panels. I believe that Congress needs a fuller understanding of how the administration is meeting the resource needs of hospitals and nursing homes. But since she is not here, I do have a few questions for Admiral Giroir as the Assistant Secretary for Health. I think that Dr. Fauci kind of answered this question already very briefly, but Admiral Giroir, do you believe that our healthcare providers that are serving on the front lines within our hospitals have the personal protective equipment, the supplies, the resources that they need today at this particular moment?
Today, at this particular moment, I do believe they have the supplies that they need. And let me tell you, when we get a report of a nursing home or another facility that says they don't have the supplies, literally we call those places individually to understand what their needs are. So at this point in time, I think we're meeting those needs. Again, the challenge is if the first wave gets worse or we have a second wave, are we going to be able to meet those challenges? And that's what the SNS 2.0 is, to make sure we have at least 90 days. Yes, sir.
No, thanks. I appreciate that. I want to move on to the future, if you will. But before I do that, I do want to ask every one of the panelists whether he agrees that it is likely that we will, in fact, see a second wave. I know there's a lot of controversy right now as to whether we're still in the first wave, if you will, and it's sort of disproportionately the different regions of our country are dealing with it in different ways and are feeling different effects as well. But if I could just go down the panel, beginning with Dr. Redfield, and truly a simple yes or no answer, do you believe that it is likely that we will see a second wave in the fall or the winter? Dr. Redfield, you first.
Yeah, it's simple. I'm not sure I would call it a wave, but I wanted to make it clear we are going to experience significant coronavirus infection in the fall and winter of 2020 and 2021.
Thank you. Dr. Fauci?
There certainly will be coronavirus infections in the fall and winter because the virus is not going to disappear. It's too,
Okay.
yeah.
Thank you. I appreciate that. Dr. Hahn?
Congressman, I agree with Drs. Fauci and Redfield.
Thank you. And I left you to last, Dr. Gerard, a little bit out of place there. I apologize, because I do want to ask you about going forward, and in particular, what steps is the department taking to help hospitals and healthcare providers prepare for a potential, or perhaps a likely, if you will, second wave of surge in cases in the coming months? Dr. Gerard.
Okay, thank you. I don't want to take up all your time because it's really everything from understanding what the needs are to understanding the supply chains down to the individual hospital levels. Because, like I said, when we started out, it was impossible to know what supplies were being used objectively, what ventilators are being used objectively. We've gone through that all the way to the therapeutics that Dr. Fauci has talked about, and Dr. Hahn, of course, remdesivir, steroids, hopefully plasma, all these things and everything in between. It's really all hands on deck, and all our task forces are still operational, including the Hospital Resilience Task Force that is not only dealing with COVID, but if this happens again, we don't want our immunization rates to plummet. We don't want our mammograms to plummet. We don't want our colon cancer screenings to plummet. All of these things were really victims of the COVID response, just like COVID patients were. So we need to fix all of that.
Okay, one last question to you, Dr. Gerard. As you know, hospitals have struggled dramatically financially through all this, especially when they could no longer perform elective surgeries because they had to be ready for the COVID patients. And we did pass legislation here in Congress, obviously. We provide $175 billion in direct funding to providers for expenses and lost revenue. What is the status, Dr. Gerard, of the next allocations for the remaining funding that is yet to be distributed from the provider fund?
Yeah, I'm sorry. I'm going to have to take that one for the record because the secretary and the people on that side are really controlling that, but we'll be happy to supply that answer to you from...
I look forward to that. My time has expired anyway, but thank you all. Thank you, Dr. Gerard. Thank you, Chairman Paloma. I yield back.
Mr. Chairman, before you proceed, there's quite an uproar on social media about the fact Dr. Fauci has changed face masks and the implications thereof. Do you have any comment?
I'm an avid Washington National fan, so I thought I would break up this a little bit by putting on my Washington National face mask.
Okay. Thank you. Next, we have Mrs. Brooks.
Thank you, Mr. Chairman, and thank you all so very much. You got me going thinking about the Nats for a little bit. We miss all of them playing baseball. I'd like to talk a little bit about what you all suggested with respect to sustainability of funding. Dr. Redfield, I think for decades we have underinvested in our nation's public health infrastructure. Can you tell us what it is we need to do? You all mentioned sustainability, but if you could, talk with us about what steps would be necessary, not just federal government, state and local. What do we need to do to really think about our public health infrastructure in this country?
Thank you very much, Congresswoman. It's so important, and I've said this, that this now is the time. Because for decades we have underinvested in what I call the core capabilities of public health, data analytics, to have predictive data analysis, laboratory resilience, public health workforce, emergency response form, and then our global health security around the world.
And those are all the different things that you think everyone, state, local, and federal, ought to be investing in at higher levels.
And we need to do it. And when you look at it, if you didn't quite palpate it before, we're going to probably spend close to $7 trillion, all right, because of one little virus that came, which we recognized very early. We used the capacity that we have, and I said, the critics will be there, but we'll do the postmortem when we're done. We've all done the best that we can do to tackle this virus. And the reality, it brought this nation to its knees. And I would say now is the time. It requires a sustained investment in terms of the core capability. Many of you may not know the nuances of, say, funding for the agency I run, CDC, but there is no core funding. It's all through different PPAs that are provided by Congress. We need core public health funding, and many people don't know that CDC provides up to 70% of the public health funding for every state, local, territory, and tribal health department in this nation. So we got to invest in that in a sustainable way with a purpose that's core-based funding.
And might the states also invest at higher levels and local governments as well?
I think you said it right there. This needs to be a partnership.
Right.
It's not all the burden of the federal government to invest in public health at the local level. In the reality, if your funding of CDC was to go away tomorrow, public health infrastructure across this nation would just crash. Because we're right now the backbone of it, and it should be a partnership.
Thank you. I want to talk, Dr. Hahn, a little bit about Operation Warp Speed. Really sounds like an exciting effort. It's a great project. The United States is the global leader in vaccine development. But I have to tell you, because we are working at warp speed, and your companies that you're working with, and all of the government agencies, NIH, everyone is working at warp speed. There's many who have concerns about vaccine safety and efficacy, and that when we get to that point, which hopefully weighs about the safety and the efficacy and the steps that we're taking to make sure that when that vaccine does break through, that it will be safe for everyone to use.
Thank you, Congresswoman Brooks. Really appreciate the question. And Dr. Fauci certainly, as a world's expert, can speak to vaccine development. I can tell you from the regulatory perspective of FDA, we have world-leading experts in the assessment of vaccine safety and efficacy. The world looks to FDA, the world looks to the U.S. To actually make those assessments. What I can promise the American people, we will work with companies, we will work with Operation Warp Speed to provide the assistance so the right studies are done with the right information, but we will independently look at those data and we will make a decision in the best interest of the American people with respect to safety and efficacy. We will use science and data to do that.
So, Dr. Fauci, maybe I should have started with you before going to the regulatory side. So what would you like to say to the American people?
I think that Dr. Hahn said it very well, but I just want to emphasize, I think there were some good intentions about using the word warp speed, but I myself flinched a little because I know that people might think it's reckless because it's warp speed. It isn't. There are risks, but the risks are all financial risks. And that's what people need to understand. They're not compromising the safety at all, nor is there compromise of scientific integrity. When you do a vaccine under non-emergent conditions, there are various steps. And because companies make investments in this, what they do is they don't make an investment in this step until they're pretty sure this step works. And then they go to the next step. And one of the most important steps is when you start gearing up to make many, many doses. You're not going to make an investment of $500 million or more to produce doses unless you know it works. So what this particular program says, we're going to assume it's going to work. So we're going to put investment in preparing the sites for a phase 3 even before we knew that the phase 1 was successful. We're going to be making doses even before we know it's effective. So what you're doing is you're cutting down on time, but you're not cutting down on the process of safety and science. So if you lose, the only thing you lose is a lot of money. Now, nobody likes to lose a lot of money, but we feel we'd rather lose a lot of money and gain 4, 5, 6, 7 months than have a result and have to wait 4, 5, 6, 7 months to get the vaccine.
Thank you. Thank you. I yield back.
Thank you, Mrs. Brooks. And now we go to Mr. Schroeder from Oregon.
Thank you, Mr. Chairman. I want to thank everybody here for all the hard work you're doing. But I'm concerned, very concerned, that the American people are laboring under some gross misapprehensions as a result of some of the information that's out there. Dr. Fauci, what's the average time to develop a vaccine? Mike, please.
It depends on the vaccine and the situation in which you're doing it. If you're developing a vaccine in the middle of an
What's
outbreak,
I'm just asking, what's the average?
about 7 years.
All right. And what was the fastest we've ever done? What's the quickest a vaccine's been developed to date?
Well, it's probably, I think the Zika vaccine, which we developed, was about 1.5 years, but it was never brought to full fruition because Zika kind of disappeared.
So and say there is a vaccine, what's the probability that a vaccine comes to market, actually?
Oh, if it's successful, it's a high probability.
No, I'm just saying, all these vaccines we got out there being developed, what's the probability they're going to make market entry?
There are more failures than there are successes.
It's about 6%.
Right.
What's the chance that even with a vaccine, this virus will be eradicated? And I'd look to flu for a little bit of an example, influenza. How effective is that vaccine?
The influenza vaccine is variable because the virus changes rapidly.
Much like this virus.
We don't know that yet.
Well, we already know it's mutated, right?
Yeah, that doesn't make any difference. All RNA viruses mutate. That doesn't mean they change.
Well, if I was a mother or a hardworking American citizen, and and I'm trying to bank on my family's future, how long do I wait? We're very worried that many Americans are waiting until there is a vaccine, maybe 1.5 years at best, out there, and that's going to be the panacea, and they're all going to be okay. No. I think that's a terrible miscalculation. I'm not blaming anybody here, but it's a terrible miscalculation on the part of many Americans, and I'm going to stay home, not go to work, not send my kid to school, and I'm going to hunker down, and I'm going to be okay. I'll just wait for that vaccine. I think we have to start talking in terms of vaccine as one of many tools in the toolbox so we don't end up in particular problems. Dr. Redfield.
I agree with you completely.
Well, I need to get out there a little bit more. Dr. Redfield, to that end, I'm very concerned with the school year coming up. The CDC never recommended closing schools this spring, and yet many school districts across the country closed. Right now, the CDC guidance talks about different considerations. How likely is it that a second grader, or frankly even a teenager, is going to maintain social distancing of 6 feet all the time?
I think you know the answer to that, Congressman.
All right, thank you. It's a rhetorical question. I appreciate that. How about a school bus, where you're supposed to have one child per row? School districts, maybe in some states, are much more flush with money than mine. We can barely afford the school buses we have now. What's the chance of having, 3 foot or less?
Yeah, I think you raised the reality as we look at.
I'm sorry to interrupt. I have limited time, but some of these are rhetorical. But I'm just worried that we're making all these pie-in-the-sky public health perfection recommendations that have no chance in hell of actually happening at the local level. They don't have the money. They're dealing with human nature, especially children. Look, adults aren't much better from what we can see around the country. But poor children, we have to have recommendations, I think, that are realistic. What's the incidence rate of this disease in children?
We still don't know the infection rate in children, but we do know when you say disease.
Internationally, it's less than 2%.
When you say disease.
Dr. Fauci makes the correct comment that, but they can infect others. It would seem to me a smart use of our precious dollars. You talk $7 trillion. We don't have $7 trillion, doctor. We spent over $3 trillion, which is twice what we spend in a year. We did that one bloody month for a good reason. And hopefully, you guys are showing us good results, and I appreciate that. But we need to make sure that citizens out there aren't withholding Johnny and Susie from going to school because they think, this is all going to be over in 1.5 months or 2 months. That's what the president tells them. That's what we're telling them, or they're getting that impression. That's wrong. And if we have kids not going to school, we run the huge risk of the wealthy kids get a great education online with their nice moms and dads. The lower income kids get no education. And
the comment I would like to make is that it's so important, the inference of what you're saying is we need to use the knowledge that we have now, which we didn't have then. As you know, CDC did not recommend closing schools.
Yes, sir.
Okay?
Thank you.
And we didn't recommend it because we didn't think it was a one-size-fits-all. We close schools jurisdiction by jurisdiction when we see issues in the schools. So I do think we have to focus as we move forward in the fall and now, what I said before, on the consequences of this virus. And those consequences are mortality and hospitalization and the economy, right? And I think when you see that, you'll see that different recommendations for the jurisdictions will come to rise. And as I said, I'm pretty confident we're going to be opening our schools, and your comments are true. We need to open our schools with the reality of how we expect those schools to act based on the consequences of what we think this virus is going to pay for those individuals in school. That doesn't mean we don't have to be vigilant about protecting the vulnerable. You need to work on that in those families, but no longer does that mean we have to shut down schools, shut down, you know, the economy. It means we have to focus on how to prevent the consequences of this virus.
Thank you very much. I'm sorry for the line of my questioning.
Thank you.
I yield back.
Now we go to North Carolina. Mr. Hudson.
Thank you, Mr. Chairman. Thank you for holding this hearing today and for convening such an esteemed witness panel. Admiral Gerard, it's a pleasure to see you. I appreciate all the work we've done together, particularly on the opioid epidemic. I want to thank you and all of the distinguished witnesses for taking time out of your very busy schedules to be with us here today. I first want to give a lot of credit on our coronavirus response to President Donald Trump and to the individuals on this panel who have worked tirelessly to get us to where we are. The Trump administration has taken decisive action early and often to combat this virus and keep us safe. 11 days after the first confirmed case in the United States, President Trump declared a health emergency and restricted travel from China and any foreign national who pose a risk of infection. And a little less than 2 months after the first confirmed case, President Trump declared a national emergency. Same goes for our testing capacity. The Trump administration has gone from a few thousand tests a day in March to close to 500,000 tests a day in June, and anticipate being able to perform 40 to 50 million tests a month by September. That's a staggering improvement for a virus we knew nothing about last year. This is not to mention the Herculean efforts made on PPE with Project Airbridge and ventilators with all the public-private partnerships to grow our capacity. As we've all grappled with the coronavirus outbreak, we've all had to acknowledge how little was known about it. Even months after its arrival, we're still grappling with questions such as how and if it will mutate, if our immune system can develop appropriate antibodies, and what, if anything,
I am absolutely committed to aggressively getting this information. It's not only African Americans. African Americans have suffered horribly with this disease. Latino Americans are also at very high risk, and the highest risk are Native Americans and Alaska Natives who suffer even higher rates. So all these are critically important to us.
Yes, sir. Thank you. And as I noted earlier, the Trump administration has greatly increased our testing capacity. One area that has had uncertainty, though, is the serology testing, something that could help us tremendously as we reopen the economy. people move back to work. Commissioner Hahn, in recent months, we've seen a large number of serology tests enter the market, some decisively not as accurate as others. The FDA has since taken action to remove several of these. How is the FDA ensuring that only high-performing serology tests are available in the U.S. market?
Congressman, thank you for the question. As I think you know, when we issued our original regulatory flexibility around serology testing, it was not known completely how these tests would be used and what the operating characteristics of them were. Our guidance allowed these to be used in a real-world setting. At that time, we required the manufacturers to certify that the tests had been validated. We found that in some cases that certification was not correct. And so we developed a partnership with the National Institutes of Health, NCI, to actually do a U.S. government independent validation. And as you probably know, sir, over 20 of those tests have been taken off the market. We have subsequently required that all manufacturers provide us with that manufacturing data, and if they don't, they have to be removed from the market. We continue to look into that, and we'll continue to follow that policy, sir.
Thank you. Mr. Chairman, I see my time's expired, so I'll yield back.
Thank you. Next, we go to Mr. Kennedy in Massachusetts. If unmute. Joe, are you there? Did you unmute? Huh? He's on mute. Joe, you have to unmute. I think he's there, but he's still muted. You're still muted, Joe. What do you want to do? Mr. Kennedy, you're speaking, but we can't hear you. Are you there? All right, we're going to go on. We'll come back to Mr. Kennedy. Next is Mr. Cardenas. Mr. Cardenas, unmute. Maybe there's a technical problem. I don't know.
There you go. Can you hear me now?
Yes. You're
Okay,
recognized
thank you
for
so
5 minutes.
Thank you so much. Thank you, Chairman Pallone and Ranking Member Walden, for holding this important hearing. And thank you to the expert witnesses that we have before us. And we all appreciate all the work that you're able to do when you're allowed to do it. This February, there's been a steady flow of reports of Centers for Disease Control and Prevention, otherwise known as the CDC, being sidelined. Its experts have been overruled. And in the midst of a pandemic, this is unacceptable. Dr. Redfield, earlier this month, you expressed concern that the CDC's public health why hasn't the CDC held regular media briefings during the pandemic, as the CDC has done during past public crises, where it can provide clear, evidence-based information directly to the public and where the media can ask questions? Is it possible the lack of regular and direct communication from CDC has been contributing to the public's confusion about how to best protect themselves in this health pandemic crisis?
Thank you very much, Mr. Congressman. The CDC has communicated in different ways. Clearly, first and foremost, we've put out over 1,500 guidance or
excuse me, Dr. Redfield, the president has proven very, very clearly that when you get in front of a podium and you actually have a press conference, you have a higher likelihood that you're going to reach more people. My specific question is, why aren't you having more of those press conferences like the CDC has done previously?
And I was trying to add that through our things, we've reached 1.5 billion people so far. We have regular conferences with the local, state, territorial, tribal health departments every week, almost and every day. We have special conferences reaching out to special interest groups, whether it's business, faith communities, et cetera. We have also, had conferences, as you know, and we've reinstituted our now bi-weekly press conference with the open press. And so I do think that CDC does continue to communicate, but more at the local level than, let's say, at the national level.
Thank you, Dr. Redfield. You actually answered my question, and I appreciate all the local work you've been doing. But in the past, the CDC has been more of a national presence and a voice in previous issues where we've had health crises. And I hope that you're able to change that and continue doing your local, but actually be more present on the national, as the biggest voice on the national stage has been President Trump. And there's no question that he's misled the public, certainly with his actions and his words, by not wearing masks and refusing to do so, and actually telling the public that he's not going to do that. In February, Dr. Messonnier with the CDC warned us that the virus could possibly cause severe disruption to our everyday life. She was right. Yet she was contradicted by both the president and Secretary Azar. And in April, Dr. Redfield, you confirmed that a second wave of the virus in the fall could be difficult, and President Trump immediately contradicted you in real time. And I'll quote him. The president said, "You may not even have corona coming back," end quote. Dr. Redfield, do you believe the public would have been better prepared and state and local public health officials better supported to face this pandemic had CDC and other public health experts not been ignored or contradicted at the national level, like the president contradicted you in real time?
Well, I think, Congressman, obviously we continue to try to get our message out. I thought Dr. Messonnier obviously did a service in sharing her perspectives at that time and letting people understand what could be on the horizon, which obviously eventually was on the horizon. I've tried to do the same in making the American public prepared that this fall and winter is going to be difficult, and we need to be prepared for it.
Thank you, Dr. Redfield, and thank you for complimenting Dr. Messonnier for her bravery and her willingness to speak up at the moments that is necessary. I'm concerned, gentlemen, that we have a problem right now that over 120 lives have been lost in the United States due to COVID-19, and yet the public is still not on the same page as they should be when it comes to how to protect themselves, and they're getting missed messages at the national level from our leaders. So what I hope and pray is that the CDC make its presence more aware and more clear with evidence-based advice to the American people. And then also, I gotta hope and pray that, and I'm gonna ask some questions to be forwarded back to the committee as to the misleading statements, such as touting the fact that PPEs have been provided to the American people to the tune of a few million here and there, when in fact, some of you have actually reported that ideally we should be in the billions of PPEs. And I'm going to ask those specific questions so that the full public can hear the answers and we can have it on the record of this committee. My time's expired. I yield back. Thank you.
Thank you. Next, we go to Mr. Wahlberg from Michigan.
Thank you, Mr. Chairman, and thanks to the panel for sticking with us for this lengthy period of time. And thank building on the fly to some degree. As we've discussed already, and as you know, there were a handful, 5 states to be exact, including my state of Michigan, where my governor required through an executive order, nursing homes to admit COVID-19 positive patients back in their facilities. This proved to be a terrible policy, as we found out, with the consequences for our seniors, with almost 2,000 nursing home residents in Michigan having died. That's accounting for 1/3 of our state's COVID-19 deaths. Dr. Redfield, some officials in the 5 states that issued these executive orders have indicated they were following guidance from administration. What guidance? And you used that term expressly earlier on, and I appreciate that, because I think that's what we do give at the federal level when we talk to the states. But what guidance did HHS and CDC release as it relates to admitting COVID patients in the nursing homes? And secondly, what obligations are states under to follow that guidance?
Thank you very much, Congressman, for the question, important question. CDC did, in fact, and does, in fact, have guidance for nursing homes. The guidance that you're referring to was guidance that was grounded in the fact that some situations were that nursing homes were refusing to take any COVID patients at the time. So CDC did issue a series of important prerequisites that the nursing home had to have in place in order to accept these patients that they had admitted to the hospital back when they came back. Fundamental to that was that they had the appropriate facilities to isolate that individual. They had the appropriate not saying you have to take somebody back, it's that you have to be open to taking care of COVID patients, provided that you have the capacity to do it correctly.
And correctly is the key thing.
And correctly, and so that that patient doesn't spread the infection to other individuals. And I think some of the speeches that we've heard in the press fail to understand that it's to do it correctly. As you know, over half of the nursing homes in this nation right now, over 7,000 nursing homes in this nation have a COVID patient in them. The question is how to do it correctly and safely.
And save the lives, yeah.
And save the lives.
Well, it gets down to data as well. So let me ask you, what are the obstacles to collecting and reporting the data that you are now requiring, and my governor has finally started to put out? What are the obstacles to collecting and reporting this data, particularly among data collection from the states?
CMS has now required, as you know, that nursing homes are reporting their data. They report it to CDC, and then CDC reports it on to CMS, and CMS has it's actionable. Right as we sit here today, a majority, over 90% of nursing homes, I think it's north of 80, I think we're almost at between 80 and 90% are actively reporting through our system already since that request was required a couple weeks ago. And we're working to get all 100% of the nursing homes to be reporting as required by CMS. And that data it also is complemented. I mentioned earlier about the ethnic groups and data. That data actually comes in originally with now all testing. You all have helped us in that now any test that's done for COVID has to come and has a series of key data points to include ethnicity and race so that we can maintain that for all cases across the country, independent if they're nursing home or not.
Thank you. We hope it helps. Dr. Fauci, 3 questions that I have for you relative to yesterday. University of Michigan announced its plans for fall semester to consist of a mixture of in-person and remote classes. As schools prepare for the fall semester, what factors should they be considering? And I'm thinking of higher education here. What do we know about the transmission of COVID in young adults that would help inform the decision to reopen colleges and universities? And thirdly, should reopening look different for a school like University of Michigan versus a school like Hillsdale College in my district with 1,500 students in a rural community?
Yeah, all good points. Again, one answer could probably spill over into each of the questions. You really have to consider what the state a few cases, like in a small college in a county, I think you can be really very liberal in the opening. What schools are doing, and they're doing it in a very creative way, is to try and make sure that there is separation enough that you have situations where, first of all, masks should be done at all times, without exception. You've got to protect the vulnerables. You've got to allow both faculty as well as students who are in that category of underlying conditions to be able to have the capability of either teaching or learning online. You have to have the capability of, when you get an infected student, which you invariably will, no doubt, to be able to remove that student to a safe, comfortable place for the period of time until they can go back. If you leave them in the community, you're going to wind up having a situation that could make the whole thing fall apart. That's just a few of the things we need. Situation. The other thing is people who work with the students, namely people who feed them, people who clean, they need to be also paid attention to, because often, be it in a cruise ship or be it on a nursing home, it's the staff who might bring in an infection and then infect the individuals who are in a much larger group.
Thank you. I yield back.
Thank you. We're going to go back now to Mr. Kennedy.
Hopefully this time it works. There you go.
We can hear you.
All set, Frank? Beautiful. Mr. Chairman, thank you. Apologies for the interruption beforehand. I want to thank our witnesses for being here. Chairman, thank you for calling this hearing. And to the witnesses, thank you for your service and your willingness to stay so long through the afternoon. I want to start, this was now about a month ago. I had been in Chelsea, Massachusetts, community average. I was delivering meals at a nonprofit, local nonprofit there, with food lines longer than I've ever seen anywhere in the world. And on my way out of the community, I called one of the heads of the local community health center, and I asked what else they needed for help. The individual I spoke with said that they had recently received some mapping software, and they were looking for cool spots in the community. And I asked him, why cool spots? Aren't you looking for the hot spots? And he said, no, we know that everybody's been exposed. What those cool spots will tell us is where we haven't been testing. You know where the biggest cold spot was? The public housing facility, where in a population of 900 people, 4 had been tested. 4. This administration has failed so completely to prepare our nation for this pandemic that working communities largely made up of people that our government and our society have deemed to be essential. Just days ago, President Trump stood up before the American public and told us that he asked his administration to slow the tests down because what they revealed was that tests were accelerating and it was instrumental to his political survival. And I know we've received testimony today that his statements here were not true, although the president has also contradicted that again, saying he does not joke. But to my people in Massachusetts and our people in Chelsea, made up predominantly of Black and brown men, women, and children, this administration's failure to test was no joke. It's been deadly. We have over nearly 120,000 people that have died, over 2 million that are sick, and 45 million Americans that are out of work. We're 4 months into this crisis, and the administration's best plan to confront the racial inequities that we're talking about is collecting long overdue demographic data. And yes, we need that data. We know that Black and brown people across this country are more than likely if you are Black and in Washington, D.C. In Massachusetts, the positive rate among Black and brown residents is 3 times higher than for white residents. So yes, we need more data, but only because the administration spent months ignoring what advocates had tried to warn us about in the first place. So let's talk about the actions this administration is taking to confront these inequities. Dr. Redfield, I'll start with you. The CDC finally released guidance requiring demographic data from commercial testing companies earlier this month, but it does not take full effect until August 1st. Do you believe that that lag time is acceptable as thousands are diagnosed still every day?
Thank you very much, Congressman, for your question. I can say that we are committed to making sure that we get comprehensive data, particularly on race and ethnicity, as well as data on these underlying comorbidities, so we can better understand.
I appreciate that, Doctor. We're talking about collecting it on August 1st for a virus that arrived on our shores in January and February. So I've limited time. That delay seems to be quite substantial. I want to move on because there's news that I think broke today indicates that the federal government is going to stop supporting testing sites in Texas and other states. We see skyrocketing numbers of cases. Does stopping federal support for those testing sites, is that going to be effective at helping to mitigate the spread of the virus?
So I'll take that question. Thank you very much. The only testing sites, so the first set of testing sites were 41 sites that were completely federally run under federal contracts. The retail sites have now been over 600. Of testing sites. The only sites that we sunsetted with the full agreement of the governors, because I spoke to all of them, were 13 remaining sites, 7 that were in Texas, that were of the 1.0 variety that had really that were ready to go because there were so many other sites around them. We matched each site to FQHCs surrounding them, to retail sites. So we are not withdrawing the support for well over 2,000 sites. We're just transitioning those 13.
And very quickly, briefly, because I don't have much time here, but we have seen 45 million Americans lose their jobs. Yet we have an administration that continues to push the need for work requirements for individuals on Medicaid. Yes, we'll go down the list, starting with Dr. Fauci. Do you believe that implementing work requirements is going to be an effective measure to stop the spread of coronavirus?
We're going to have to just limit you to the response, Dr.
I didn't get the, I'm sorry.
He asked about work requirements.
Now that 45 million Americans have lost their job, is implementing work requirements an effective way to stop the spread of coronavirus?
Sure, I'm qualified to answer that question. I've really not been involved in
Very
that.
qualified to answer that question, Doctor. Respectfully.
I didn't even hear, sir, I'm sorry, but I really didn't even hear the question or understand it. So I'm not trying to evade.
No. Okay, let me clarify if the chairman will give me 1 minute. Given that 55 million people have lost their job, and the administration still continues to go forward in trying to implement work requirements, will the implementation of work requirements be helpful at stopping the spread of coronavirus?
Right, yes.
All right, I don't know if your mic wasn't on, but. All right, we're going to go now from Massachusetts to Savannah. Mr. Carter.
Thank you, Mr. Chairman, and thank all of you for being here. We appreciate it. The administration's done an exceptional job, in my opinion, of increasing testing capacity over the past several months, and I know that it is our desire and our goal to get testing to 40 to 50 million tests per month by September. And in order to do that, we greatly need to expand testing. I've said that in order to roll out our economy, we need two things. First of all, we need robust testing. Secondly, we need personal responsibility. That is following the advice of members of the coronavirus task force and making sure we're washing our hands, wearing masks, et cetera, et cetera. Admiral Gerard, earlier you said that 90% of Americans live within 5 miles of a pharmacy or a pharmacist, and I don't need pharmacists, making them the most accessible healthcare professionals out there. I wanted to ask you, and Admiral Gerard, you and I have talked about this many times before. Do you think the administration should utilize this, the pharmacy personnel and the profession for expanded testing, especially community pharmacists who can help rural and medically underserved communities? I know that we have made it to where pharmacists can provide these tests, but not all pharmacists. And what I'm getting at is if we could get to where the community in the rural and the medically underserved communities, the pharmacists there would be able to do it as well.
So thank you, Congressman. Yeah, thank you, Congressman. And you know how I feel about this. I think pharmacists are one of the most underutilized professions in the country for their training and their expertise, and also their trust from the population. And I would just like to put an exclamation point behind everything you have said. In order to work with the independent pharmacist even more than the retail pharmacist, and I'm sorry, I know this is your world, but there's an organization that's sort of an intermediary between that we're working with to make sure that we could bring more and more of the independent pharmacist under contract through our community-based testing program. But I'm all on board, whether it's telehealth, pharmacists, community health workers, we need to get health into the community, and pharmacists are a great way to do that.
Thank you, Admiral. And I've actually, I've submitted bill texts that would do just this, that all the pharmacists are on board with, and it's over at HHS right now. And I'd just like to ask all of the members here of the task force, if you could help me to get that review completed so we can move forward, I would appreciate it. Also, I wanted to talk, I've been sitting here listening to colleagues on the other side of the aisle who have been saying that the administration and this task force has not done enough to save lives. And as you know, we've talked about the fact that we've had 42% of the COVID deaths have been from 0.6% of the population, and that has been nursing home residents. Now, I do not in any way consider myself to have more expertise on communicable diseases than any of the four of you who are sitting here today. However, I will tell you that in my professional career as a pharmacist, I was a consultant pharmacist and I worked in nursing homes. I spent almost 30 years in nursing homes. So I do know nursing homes, and I know that's the last place that you want a positive patient to be at. And I just want to point out that, in fact, I can remember servicing a 100-bed facility years ago that, for whatever reason, did not get the flu vaccine. And we lost almost 20% of our population in that nursing home as a result of a flu outbreak because we didn't get the flu vaccine that year. So I have seen this firsthand and I've experienced it. And that's what upsets me so much about the decision of some of these governors to put these patients in the nursing home, which would have been the worst place they could have put them in. Now, I say all that to say that, I still believe in humanity. And I don't think any of those governors who made that decision did it intentionally. And I don't think they would have done it if they had known what it would have resulted in. And I say that to point out to all of us and on this committee and to everyone in Congress that I think the administration has done an outstanding job. And I think they've saved lives. Now, have they done everything right? No. No, they haven't. And would they do things differently if they could? Yes. And I believe that these governors would have done things differently if they could. But to point fingers and say that no one cared about saving lives, I think that's despicable. And I don't think that's fair whatsoever. Dr. Redfield, I know that you seem to have had a bullseye on your chest today for whatever reason, but I know that the CDC has done some great things and made some great positive comments. Can you just tell us some of the useful materials that you've released from the CDC?
Well, we've put out the guidance really in a variety of different areas, as you know, and obviously focusing on nursing homes, focusing on obviously individual mitigation steps to limit the spread, focusing on first responders, healthcare settings. I will say something about the nursing homes that I really hope we consider. As we're looking to the fall, I think there needs to be more serious consideration in jurisdictions that have multiple nursing homes to look at whether certain nursing homes are prioritized for COVID patients just because of the situation we went through before. But we continue to put guidance out on them going back to school, going to camp, daycare centers, K through 12, wherever the American public seems to have a need for guidance, we either put out a guidance document or we put out what we call a consideration document, which it gives people some better understanding of the impact of COVID and how they can protect themselves safely in those particular environments.
Thank you.
Thank you. And thank all of you. And I yield back, Mr. Chairman.
Yeah, I just want you to know we got 10 left. So hopefully, if you have to take a restroom break or something, just go out and come back. Are you going to be able to stay with us for these 10? We'll try to make it brief. All right. Mr. Peters of California is next. You want to unmute, Scott?
Yep, just kidding. Thank you. Facing has come in large part due to the failure to develop and deploy sufficient diagnostic testing in time to monitor and control the spread of the virus. In February, on the 29th, after it became clear that CDC's tests would not be able to perform, FDA began authorizing the emergency use of molecular diagnostic tests. And since then, FDA's authorized more than 110 emergency use authorizations, has issued more than 110 authorizations for diagnostic tests. And that's done a lot to increase our overall testing capacity. Unfortunately, we still don't know much about the accuracy of these tests. And while we might typically expect the test to undergo large patient studies to determine the level of accuracy, the emergency use authorizations require a much lower standard, so only a small number of validation steps. While most screening tests will never be 100% accurate, false negatives can lead to that they use to screen individuals before they visit the Oval Office may produce false negatives 20% of the time. So Dr. Hahn, FDA has said that it has asked test manufacturers to conduct follow-up accuracy studies on tests that have received emergency use authorization. Can you tell us how many of these tests have you requested follow-up accuracy testing on, and of that number, how many have been shown to be accurate?
Thank you, Congressman, for that question. And just want to emphasize the point that you made, which is that in an emergency situation, our EUA authorities allow us to look at the risk-benefit. And early on in a pandemic with limited numbers of supplies, but reagents to test the actual diagnostic accuracy, we rely upon a certain set of data to make that decision initially. For a number of companies, and they have come back to us with those data, and we have made adjustments to the EUAs for those tests. But even in those situations where we haven't required formal post-marketing assessment of the tests, we have collected on our own and with the companies and with academics real-world data. We incorporate all those data into our assessment of the tests. And I'll just take, sir, for a moment, serology tests, where we've taken over 20 off the market based upon our own independent evaluation in U.S. government. We will continue to make those efforts, and we will continue to look at those data and adjust our recommendations and tell end users, be very transparent about the operating characteristics of the tests so that they can use them in the best way possible.
About how many adverse events reports have you received on diagnostic tests so far?
Sir, I'll have to of reports about all of these tests, but I'd be glad to get those data for you, sir.
Okay, and just to confirm, if a follow-up accuracy study comes back and a test shown to be inaccurate, you've moved and you'll continue to move to take those tests off the market.
Absolutely, sir, and we promise to be transparent and post that on our website.
Thank you very much. I want to ask Dr. Redfield a question about digital contact tracing. Do you agree that digital contact tracing tools can enhance our traditional contact tracing efforts, particularly proximity tracking tools that use Bluetooth technology to identify people at risk of COVID-19 infection?
Thank you very much for the question. Clearly, these new digital technologies that have been developed for contact tracing are important to be evaluated and to see how they will contribute. I want to believe of contact tracing is the human capacity to do that, and this is why we're working to aggressively increase the number of contact tracers. But we currly are in the process of evaluating it to see if it's value added.
I only have 45 seconds. Dr. Redfield, let me just point out, I would really think there would be a shame if we took the technology from the 1980s and didn't employ the technology that we have today. Bluetooth technology can tell you who you've been around within a certain proximity with great accuracy, with great speed. It can be anonymized so that no one knows who the particular person is. But if you have your Bluetooth on, you don't have to know who you were standing next to at the protest or in the restaurant or in the bar. If a person test is positive, it can go into a system, and Google and Apple, MIT, UCSD are working on these things so that you could be automatically, almost in real time, warned that you've been in proximity to someone who's tested positive and can behave accordingly. For speed and for your accuracy, I hope you'll give a good look to Bluetooth technology, because it can be private and it's certainly more accurate and certainly faster than the technologies we used back in the 1980s. We can do better, and I yield back.
Yeah, I just want to emphasize, Congressman, that we are aggressively evaluating that technology with Google, Facebook, to actually see how it impacts it. So I agree with you, it's really important. We have programs evaluating each of it in partnership with Google and Facebook right now, and we will continue. The question is just to see exactly the best way for this technology to be used. It's not a question of not seeing it as something that potentially could be very important.
Thank you. We're going to go to Montana now, Mr. Gianforte.
I want to thank all the witnesses for their time today. The people of Montana appreciate you and all the health professionals who are working so hard to keep us safe and deal with this virus. As we mourn the lives of those lost to COVID-19, we must also think about how to continue to safely reopen our nation. Testing is critically important to both help limit the spread and restore confidence to the public. Montana has seen an uptick in positive test results, but not a large uptick in hospitalizations. This could be seen as indicating that increased testing is finding more mild and asymptomatic cases. I've heard from hospitals and private labs across Montana that they'd like to provide their own testing services to help their communities and provide certainty to large employers, as well as rapid response capability for tourists that are coming to see our national parks and great public lands in Montana. Admiral Giroir, there's been an enormous increase in the availability of diagnostic testing since the early stages of the pandemic. Test manufacturers rapidly scaled up their production capacity to meet the unprecedented need for testing. Could you describe for us the administration's collaboration with the private industry in establishing this massive diagnostic and serological testing infrastructure and the availability of supplies for state health agencies, as well as the commercial supply chains?
So thank you, and I will try to be brief because I know your time is limited. It's really spanned, as you said, it's a public-private partnership, and we have been working very tightly with FDA as well, because innovation has been key to that. Just to give you an example, when we opened our first 41 testing sites, using nasopharyngeal swabs, which would require full PPE and full PPE changes, if we ran those 41 sites full-blown, we would have exhausted 80% of the stockpile for PPE within the first week. So it was really vital that the FDA was able to work with sponsors to validate other types of equipment to expand our supplies. Let me just say that the public-private partnership, whether it's working with the ACLA labs, that's the Quest, LabCorp, Mayo, BioReference, they've done over half the tests in the country to date. It's been absolutely critical. Every laboratory manufacturer that supplies test kits for these laboratories are working with us. We have a relationship manager with every one, so we know what their limitations are. Can we get around it with the DPA? Can we help them with their supplies? What can we do to maximize the number of tests moving forward? And again, I'll just say with Montana, it's been a real special case because although we have lots and millions and millions and millions of tests, there are only a few that are really geared to rural areas, and they're in very short supply. So we've been working very closely to get, for example, the Cepheid test and the point of care to Montana, because you're not in the middle of New York City where you have the multi-million-dollar machines. You're really in a rural area like in Alaska. So it's not just the numbers, it's the type, and it's the mixed with innovation.
Great. Thank you, sir. And it sounds like the public-private partnerships have really been central to your strategy to scale up testing capacity. What efforts are ongoing in that area to further develop public-private partnerships?
They really have been critical because the public health laboratories are an essential first line of defense. But as of now, they've only done about 7.5% of the overall testing. So the majority of what, overall, it's the hospitals and academic institutions and about half with the commercial sector. The swabs, you've jested about swabs. When I dropped into this on March 12th, I thought we had 10 manufacturers, 12 manufacturers. There was one in Italy and one in Maine, and everybody repackaged the same product. And it was the hardest to make, most difficult to get, was the only one that was authorized. I never thought I'd send a C-17 over to Italy to pack a C-17 full of swabs, but that's what we needed to do. So the public-private partnerships, whether it's in manufacturers, the retailers, and the pharmacists, have been absolutely essential. It's really the only way to scale what we needed. If you have a small outbreak, you could do it within the traditional infrastructure. But like in World War II,
thank you, sir.
Everybody has to participate.
Yeah, thank you, sir. Commissioner Hahn, in the limited time I have here, a health professional in Montana wanted me to ask if you have confidence in the accuracy of the antibody tests currently available and what steps are being taken to ensure we avoid a supply crunch for those tests as well.
Thank you, Congressman. We have authorized over 20 serology tests. My recommendation to the users across the country, and particularly public health, is to use those tests that are authorized under the EUA process with the FDA. We are undergoing an independent validation of data that manufacturers have sent to us to ensure that we can actually corroborate what the manufacturers have sent. If we are not able to do that, we are asking those and taking those off the market. We're being very transparent on our website, and I'm very happy to have a conversation with the health professionals in your state, sir.
Okay, thank you. And Mr. Chairman, I yield back.
Thank you. We're going to go now to Michigan, Mrs. Dingle. We're coming to you from the Dingle room there.
Thank you. Thank you, Mr. Chairman. And I want to thank all of our witnesses for being here today and your patience in dealing with all of us. Believe it or not, there is widespread agreement on something, which is that we're not going to be able to safely return to anything resembling what we once knew as normal until we have a safe and effective vaccine. In Congress, we've moved quickly to facilitate development of such a vaccine, investing billions of dollars funding at BARDA and NIH. Public and private researchers have taken those resources and run with them, speeding through the phase 1 and phase 2 trials, clinical trials, with multiple companies now announcing that they're about to begin phase 3 trials as soon as next month or soon after. This speed is unprecedented. And I want to be very clear as I ask these questions, I am not an anti-vaxxer. Vaccines have eliminated disease and extended lifespans. But as members of this committee have been told many times, phase 3 trials are where the rubber meets the road in developing a new drug. It's where you test a new drug in human patients on a wide scale, evaluating constantly for side effects and ultimately determining the effectiveness of a vaccine. One of the vaccine candidates, which is working with NIH, has announced that their phase 3 clinical trial will enroll 30,000 patients. And another Operation Warp Speed candidate company has said it will enroll 8,000 patients. These are much lower than historical vaccine trials, which have enrolled 60,000 to 70,000 patients in the past. And I know that there can be consequences. I was one of those unlucky people that got Guillain-Barré after the swine flu shot decades ago. But to this day, I know the benefits of the swine flu shot far outweigh the risks, and that we must develop this vaccine. But we got to talk about important issues so people believe in this vaccine. Dr. Fauci, will you explain the importance of testing larger populations in phase 3 clinical trials?
Yes, thank you very much for that very important question. The size of the trial is calculated really on a statistical basis of the number of infections that you might need to get a certain percentage of efficacy. So you figure out, do you need this level of efficacy or this level, and how many hits or how many events do you need in a trial? And it was based on that that the statisticians came up with a 30,000 person. I want to point out something that I think you were hinting at, and I agree with you completely. You want to make sure, particularly when you have a new vaccine for a brand new disease, that not only can you get a signal of efficacy, but you really feel good about safety. And the more people you get in the trial before you release that vaccine to the public, the more confident you are in the safety. We are going to have a different kind of an approach, Congressman Dingell, to the phase 3 trial. We're going to have subsets of that will be looked at much more carefully for safety, particularly for the concept and the phenomenon of enhancement, because that's one of the things we're concerned about, that paradoxically, if you get a suboptimal response to the vaccine and you do get infected, you could actually have an enhancement. So I hear you very, very loud and clear. Safety is a very important issue, and we're going to be paying very close attention. You may not have heard or not, my comment early on in the hearing when I said I wanted to make sure that before we let a vaccine out to the general public, we're as confident as the efficacy as we are of the safety. And I promised you that I will be an advocate for that very, very strongly.
I did hear you, and I do trust you, but I still had to ask the question. I want to ask Dr. Hahn a question very quickly. A number of observers have said that we won't know the vaccine's long-term safety and effectiveness if we moved forward with these too quickly. I hear what Dr. Fauci is saying, and I know the importance, but what steps will FDA take to ensure effectiveness in evaluating data from the clinical trial? And will you commit to receiving that full effectiveness data from phase 3 before we authorize or approve the vaccine?
Congresswoman, thank you very much for the question. And I just want to reiterate one thing I said earlier, and that is that the science and the data will guide our decisions. We have world-class experts at the FDA. We are working on right now guidance for sponsors and developers of vaccines to exactly address the question that you're asking. We will be transparent about that guidance and forward-leaning, and we will work with the sponsors to ensure that the data we need to make those decisions are available. And I promise you, ma'am, that we will wait for the data that we need to make that adjudication around safety and efficacy.
Thank you, Mrs. Dingle. Okay, now we're going to move to Mr. Veazey of Texas. Unmute, please. Mark, are you there?
Can you hear me?
Yes. You're recognized for 5 minutes.
Mr. Chair, thank you very much. I wanted to ask a question about something disturbing that I saw in Politico this morning. And it's concerning the data collections that are underway at CDC. It was implied in the article that there were attempts to downplay true statistics. And I was wondering, how is CDC determining the death count that is updated daily? If you could touch on that, Dr. Redfield, that would be, I would sure appreciate it.
Thank you very much, Congressman. There was a report. Cases are reported to CDC from state and territorial local health departments, either as confirmed cases or probable cases. They come in through different data streams, and then they're verified to get the final numbers. There was a coding glitch on June 19th from the state of New York, where there was approximately 5,000 cases that were probable cases that the coding glitch assumed that they were counted in the confirmed case list. So that one day, there was a 5,000 confirmed case undercounting, which was correct. It occurred on the 19th of June. It was identified on the 19th of June, and it was corrected. And there were no coding glitches that affected deaths.
So let me ask you, so if a patient has COVID and they die of sepsis, is that still a COVID-related death? Or you still want to count that as a COVID-related death?
It depends on how it's coded by the state health department or the city health department or the county health department, whoever has jurisdiction for that, because it's coded at the local level.
So the death count could be a lot higher than what we are seeing right now in the news.
Yeah, I think each physician tries to understand in the death certificate what the primary cause of death was. Was it COVID that then caused complications that leads to sepsis? Or is it somebody who had an asymptomatic COVID infection who got hospitalized for, say, a contaminated infection in their arm and led to sepsis? So these are individual clinical decisions that are made on the death certificate.
So based on that, what do you think the actual COVID death rate is?
I would continue to rely on the data that we have that is basically reported through the current reporting system, where it's then based on the death certificate, the actual death certificate that's defined by the clinician responsible for making that determination. And that's the numbers that we use.
Okay, thank you very much. And I wanted to ask Dr. Fauci a quick question with my remaining time. Dr. Fauci, there was a grant that it was a coronavirus-related grant that was not renewed, and I wanted to talk with you to make sure that we just get the facts straight about this, because I was really concerned about this. Do you know why this grant was canceled, or if anyone at the White House or HHS pressured your colleagues to do so? And specifically, I wanted to talk with you about the National Institutes of Health. There was a decision made by the Trump administration to cancel research on a grant that was specifically focused on coronavirus emergence while we're in the midst of this coronavirus pandemic. And it just didn't make any sense to me why this grant would be canceled.
The question you're asking, why was it canceled?
Yes. Why was this grant canceled when we're in the middle of this pandemic? It seems like it would have been very helpful for us to have this research, considering we know very little about COVID-19.
Okay. It was canceled because the NIH was told to cancel it.
And why were they told to cancel it?
I don't know the reason, but we were told to cancel it.
Okay. Thank you very much, Mr. Chairman. I have no further questions.
Thank you. We're going to now go to New Hampshire. Ms. Custer, unmute, please. Annie, you got to unmute. Annie, are you there?
I am, and I did unmute, Frank. Can you hear me?
Yes, we can. You're recognized for 5 minutes.
It's so embarrassing. I'm sorry I had already unmuted and started. So thank you, Chairman Pallone, for holding this hearing, and to all our witnesses for your patience today. In addition to efforts related to the research, development, and manufacturing of a COVID-19 vaccine, there will also be work needed to ensure that the vaccine is widely adopted and equitably distributed. Specifically, decisions about the allocation of the vaccine, efforts to support provider training, public education, and coverage considerations to ensure that the vaccine is not only available, but available to everyone in every community, including communities of color, among immigrants and refugees, those living in rural areas, and of course, our elders. In the absence of a vaccine plan from the administration, I'm concerned that attention to this necessary work is being overlooked, and we will repeat the errors and mistakes that were made earlier in the pandemic. Admiral Giroir, the framework and documents HHS has released do not address these details and other factors that will be critical to reaching COVID vaccination rate goals. Could you comment on that and the bipartisan letter that this committee called on the administration to create a national COVID-19 vaccine plan?
Thank you, ma'am. Very important question. I am not on that work group. That is Dr. Redfield and I believe Dr. Fauci, and they can answer that question for you.
Great, thank you. I'd appreciate it.
Thank you very much, Congresswoman. This is a critical area. Just as Dr. Fauci has commented how important it is that we've begun to take the financial risk to have these companies be able to start manufacturing.
I understand. I'm sorry to interrupt. Your time is short and the day is long. Admiral Giroir, what I'm asking about is not the creation of the vaccine. It's a national vaccine plan to equitably distribute the vaccine.
Right.
I have legislation to require the administration to create a plan On the equitable distribution, that's the focus of my question.
Yeah, the quick answer is that is part of the overall working plan, and it's in development.
It is not available at this time. When can we expect that it will be available?
I'll have to defer that to the Secretary of Health and the Secretary of Defense that are in charge, but I can tell you that's an essential part of the current plan to develop the distribution strategy that will also address the equitability issue.
My understanding from when Dr. Eric Bright came before our committee is that it could take up to a couple of years to manufacture the materials to administer the vaccine, and that those plans had not developed. Do you know about the manufacturing of the supplies to deliver the vaccine?
That is currently a plan that is under the purview of a combination of General Gustav Perna, who was one of the co-leaders of the Operation Warp Speed. He has been specifically brought in by the Secretary of Defense to work with the Department of Health and Human Services to make sure that not only the vaccine itself is equitably distributed, but also that all of the material that's needed for the proper distribution. So this falls under his purview, and he was specifically brought in by the Department of Defense to address that issue.
And do you know if there's a plan to promote public health messaging and materials to counter vaccine hesitation in the country?
Yes, that's a very good question. I'm glad you asked it, and I have the opportunity to answer it. What we are doing is a combination of a couple of things. Originally put together during the days when we had the HIV group, and they are now an important part of all of our clinical trials networks. So we're going to employ the community outreach mechanisms that we already have, but also the CDC traditionally over the years has been very heavily involved in making the prioritization, which usually is the most vulnerable people first. But I'll let Bob talk about that.
I'll just say very quickly that we're very involved in the critical area you brought up in developing the communication strategy. It's going to be fundamentally critical. As well as I mentioned already, we're working on developing the distribution strategy but the communication strategy is very important, and it needs to, it will be beginning to be operationalized soon, just like we're getting ahead on the manufacturing.
Thank you.
Thank you. My time is up, and I yield back. Thank you, Mr. Chair.
Thank you. Now we go to Illinois. Ms. Kelly, Robin Kelly. Please unmute.
Thank you. Yeah, I am. Thank you, Mr. Chair, and thank you to the witnesses for all their patience. I also wanted to thank Dr. Redfield and Dr. Fauci for the extra meetings with the CBC and the Tri-Caucus. As we've heard, data has revealed across the country, including in my district and in the city of Chicago, minority communities showed a disproportionate burden of COVID-19 cases and fatalities. The virus has exposed centuries of health inequities stemming from historically racist policies affecting the social determinants of health. As chair of the Congressional Black Caucus Health Brain Trust, I am concerned by this tragic reality. The most recent CDC data showed that American Indians and Alaska Natives have a hospitalization rate approximately 5 times that of whites. Black people are hospitalized at 4.5 times the rate of whites, and those who are Hispanic or Latino are admitted to the hospital approximately four times more often than white people. Despite these disparities, CDC's racial and ethnic demographic data is still extremely lacking. It is my understanding that 52% of reported coronavirus cases in the U.S. are still missing information on race or ethnicity. That is why we included a number of requirements in the HEROES Act that the House passed in May that will require the federal government to better track and publicly report COVID-19 racial, ethnic, age, sex, and gender data, as well as require the various federal agencies to modernize their data collection methods to account for inequities. Dr. Redfield, you have admitted publicly that the administration's 4-page COVID-19 demographic report was inadequate. And while you announced that CDC will require all lab tests to include information about a patient's race, ethnicity, age, and zip code, the most recent report from CDC shows that more than half of the data you have is missing racial and ethnic information. Consequently, I worry that this is a little too late and this new rule lacks a clear enforcement mechanism. What further actions is CDC taking to address these data gaps? How will CDC work with state, local, territorial, and tribal public health departments and labs to support their efforts to collect this information across the country?
Yes, thank you very much, Congresswoman. As we discussed, I think last week, we're continuing to make progressive progress and to ensure that the requirement to include the race and ethnicity issue on all tests admitted for COVID is completed. There's a progressive improvement, as I think you've noticed. The same with the hospitalizations. I think we're up to 80% now. That's still not where we need to be. We're working to get to 100%. And we're going to just continue to work with our state, local, territorial, tribal leaders to get that accomplished, as well as the laboratories and the hospitals and the long-term care facilities, because it is critical that we do have that information, as you point out.
Thank you. And Admiral Gerard, what steps is the administration taking to gather missing data, including data from minority neighborhoods and congregate facilities, homes, jails, and prisons?
I think I caught about half of that, ma'am, but let me just say that I'm sorry, it's the internet connection.
Robin, repeat it.
What steps is the administration taking to gather missing data, including data from minority neighborhoods and congregate facilities like nursing homes, jails, and prisons?
So all kind of different, very, very important subgroups that we're working with. I don't think it's possible on the testing data to reconstruct what the racial and ethnic makeup is of tests that were done in March and April and May. I don't think that's a possibility. Looking forward, we're absolutely going to mandate that. On the enforcement mechanisms that you talked about, we might want some help with that because the authorization did not have an enforcement mechanism. So we looked very deeply to do that. We were not able to do criminal, civil monetary penalties, et cetera, but we are working through the EUA mechanism. And I don't want to put too fine a point on it, but I would like to turn the switch and have this tomorrow. I would have liked to have it 2 months ago because it really is critically necessary. We're targeting our resources to those areas, but not getting all the feedback of the numbers that we need. But one thing, for example, the major reference laboratories, just to give you an idea of the complexity, they've done over half the tests. They don't collect any of those tests. That comes from tens of thousands of individual physicians, pharmacists, others. So we're working with this very complex system to make sure each of those tens or hundreds of thousands of people provide that data so we can get it. But you have my personal commitment as a person whose job, my day job, is working on health disparities to make sure we get this as quickly and as accurately as possible.
I thank you, and my office will be in touch so we can work together and we can give you the help that you need. Thank you so much, and I yield back.
Thank you. Ms. Berrigan is here. You're recognized for 5 minutes.
Thank you. Thank you, Mr. Chairman, for having this hearing. This pandemic is still raging. Over 119,000 Americans have died, and cases are still rising in 29 states with over 20,000 new infections per day. In fact, 12 states set records for the most daily cases in the past week. And we know that Black, Latinx, and Native Americans are bearing a disproportionate burden of the administration's failures to address this pandemic. Meanwhile, the Trump administration seems to have moved on. The last time the White House task force held a full press briefing was April 27th, and the task force is now winding down. Admiral Jawad is stepping down as the administration's testing czar, despite the fact that we still need to greatly expand testing. We still don't have enough tests. We still don't have enough PPE. We don't have a vaccine. And this fall, we could see another wave of infections. Yet, President Trump last month declared, and I quote, "We have met the moment and we have prevailed." Dr. Fauci, do you believe we have prevailed? Has the fight against COVID-19 been won?
I wouldn't use the word prevail. I would say that we are still in the middle of a serious outbreak. There's no doubt about that.
Instead of devoting his time and effort to taking this pandemic seriously, President Trump is hosting campaign rallies, packing thousands of people tightly together without masks, in direct opposition to the guidance of all public health experts, just so that he can hear the crowds chant his name. Clearly, this president has decided the best strategy to deal with the greatest threat against this country during his presidency is to bury his head in the sand and wish it went away. Dr. Redfield, as the director of the CDC, your advice to the president is important now more than ever. Dr. Redfield, when was the last time you spoke to the president about the country's response to this pandemic?
Thank you, Congresswoman. As I mentioned before, the interactions and discussions I have with the president, I'll keep to myself, but I do meet with the task force.
Dr. Redfield, I'm not asking for the content of your conversation. I'm asking when you talked to him last. Has it been a week, a day, a month?
Again, I'm going to stay with my same answer, that I continue to talk with the task force whenever the task force meets, and I think...
Thank you, Dr. Redfield. I think the fact that you won't tell this committee when the last time you spoke to him, whether it was days or months ago, is a real concern. Dr. Fauci, when is the last time you spoke to the president?
About 2.5 weeks ago.
Thank you, Dr. Fauci. Admiral Joie, when is the last time you spoke to the president?
It was about 2.5 weeks ago as well, maybe 3 weeks ago. If you don't mind just me clarifying, because I do think it's really important, I'm remaining the testing lead. A lot got misconstrued because I said I was not going to be 100% of the time at FEMA, because my current position also works on ending HIV substance use. So I'm still going to maintain the testing lead, but I am also integrating back into some of my other office functions.
Thank you for clarifying that. Honorable Han, when is the last time you spoke to the president about the pandemic's response and the response?
It's been some time since I spoke about the pandemic response. I did have a conversation in the last couple of weeks.
Would you say that it had been more than a month ago?
No, ma'am.
Okay. Dr. Fauci, you've been candid in the past about the shortcomings of the federal government's response and what more is needed. Dr. Fauci, as painful as this spring's shutdowns have been, if we don't put in the effort now, expand testing, prepare for a second wave, develop national strategies for contact tracing and vaccinations, could we see our progress reversed? And could we be forced to shut down again if cases again get out of control?
In describing what's going on, it's a very complicated situation and a mixed bag. There are certain parts of the country, certain areas, cities, states, that have actually done very well and are following the guidelines that we put together. The Gateway, Phase 1, Phase 2, Phase 3. New York City is one of them. Actually, Washington, D.C. is another. There are other areas, other states, other cities that have not done so well. I have a considerable concern about those because I want to make sure that we get everything under control. It is not there yet. I hope as the weeks and months go by, we will be able to do what you're referring to and mobilize the identification, isolation, and contact tracing in those states, the ones that have recently been in the news, Florida, Arizona, Texas, and those states that are now having a serious problem. So it really is a mixed bag. We have some doing really well and some really in trouble.
Right, but Dr. Fauci, just to clarify, in the areas where it may get out of control, we certainly know there are states that are doing that now, would you say that we might have to go backwards and some of the progress may be taken away and we may have to shut down?
Yeah, I wouldn't necessarily, first of all, I agree with what you're saying. I wouldn't necessarily say an absolute shutdown, lockdown. Right. But if someone is going from Gateway to Phase 1 to Phase 2, and they get into trouble in Phase 2, they may need to go back to Phase 1. I don't think they necessarily need to go back to lockdown.
Thank you. Thank you all. With that, I yield back.
Thank you. Now we go to Delaware. Ms. Rochester, please unmute.
Thank you, Mr. Chairman, and thank you so much to the panel. We know that under normal circumstances, when uninsurance, health insurance, the lack of that, as well as the underinsurance of individuals is a big problem for our country. But right now with the current pandemic and the high unemployment rate, it's an absolute crisis. I don't want to turn this into a debate about the Affordable Care Act or Medicaid expansion or any other policy disputes that we may have. The fact remains that millions of people in our country are either without health insurance or they can't afford to use it. And they are especially vulnerable right now. There are close to 30 million people without health insurance in this country. And for those people, it will undoubtedly be harder to receive testing and treatment. And when a vaccine is developed, they will likely struggle to access that vaccine. Dr. Fauci, as a matter of public health, would you agree that during a pandemic such as COVID-19, it is in everyone's interest for people to be quickly tested, treated, and ultimately vaccinated?
I agree.
And Dr. Fauci, if approximately 30 million people in this country can't easily access treatment and vaccines because they lack health coverage, doesn't that present a public health risk?
I feel as a physician, a scientist, and a public health official that everyone should have access to the kinds of things that we're talking about, testing, as well as accessibility to a vaccine and healthcare.
Admiral Giroir, the administration has suggested that money from the Provider Relief Fund, which is supposed to help struggling providers, is how it will pay for care for the uninsured. When can we expect a comprehensive plan from this administration for how it plans to provide treatment and vaccines to people regardless of insurance status?
The vaccine plan, I think, is currently underway, as you heard Dr. Redfield do that. I work very closely with HRSA on making sure that everyone can get free testing. That program is underway, and the claims reimbursement for treatment is up to about $186 million now. So I know that's ongoing and would be glad to have HRSA or anyone else answer any specific more questions that you would have. But I do agree with the premise, again, that it is absolutely critical, not only in a pandemic, but under any other times, that people who need testing get their testing, that they get the health care that they need, and most importantly, there are no impediments whatsoever to getting vaccinated.
I don't know if anyone on the panel could answer this question, but were there conversations about expanding Medicaid or opening up enrollment for the ACA to actually mitigate the risks?
So I'm just going to say that I am not a member of the task force, but am at most of the meetings as an invited guest for obvious reasons. And I think there were discussions across the board about all options. All options were looked at and discussed in order to make it was clear that the objective needed to be that no one should be waiting at home in need of care because of a lack of coverage. And I would say that every option was really looked at, and the leadership, the administration at the White House decided on this way to move forward.
I will reserve my comment to just say that I think those options would have been no-brainers. I champion legislation included in the HEROES Act that would require insurers to cover COVID-19 treatment with no cost sharing. And the HEROES Act also included a provision that would provide coverage of COVID-19 treatment and vaccines to Medicaid for everyone who's uninsured. I sincerely hope our colleagues in the Senate will take up the HEROES Act so that we can make sure that everyone in this country can access the treatment and vaccines they need. I yield back the balance of my time.
Thank you. Next is Mr. Soto of Florida. Please unmute.
Thank you, Chairman. I want to go through a little bit of a timeline. On January 23rd through 28th, President Trump received 2 intelligence briefings on the coronavirus, according to White House officials. From early January well into mid-March, President Trump deliberately misled the American people into believing the coronavirus was, quote, well under control. He declared on several occasions, quote, it will disappear. And as late as March 12th, he stated, quote, it's going to go away. The very next day, on March 13th, he finally declares the national emergency. Approximately 50 days passed from the time President Trump received his first coronavirus intelligence briefings until he finally declared the national emergency. Add in 6 weeks we lost in ramping up testing at the CDC due to contamination, and the results of President Trump's disastrous response have been deadly. The United States has more COVID-19 deaths and more cases than any country.
Again, in tune with what I just mentioned, the more that you understand the dynamics of the infection, the more that you understand the distribution, the more chance you have of better control for identifying, isolating, contact tracing, and concentrating the resources in those areas where you have the most problem. You won't know that unless you know exactly what the penetrance is in your community.
Thank you. Commissioner Hahn, there's a shortage of remdesivir in Central Florida in and around my district. Will the FDA be able to assist us with this shortage? And have we seen other shortages of remdesivir across the country?
Sorry, Congressman, really appreciate the question. We are working closely with HHS as well as the White House Coronavirus Task Force, who are responsible for the distribution of remdesivir. We do know that we have a supply in this country, and I am very happy to work with you and with others. So we're glad to have our folks get in touch with yours to make sure that there's adequately supply for Central Florida.
Thank you, Commissioner Hahn. Dr. Redfield, we saw after the nation, we lost 6 weeks in ramping up testing. And now, do you think that the United States' relationship with the World Health Organization is important to the future of combating the coronavirus, both in the United States and worldwide?
Thank you very much, Congressman. We continue to have an important public health relationship with the WHO. We've had a long history of partnership with them. We're currently involved in a number of very important public health efforts, eradication of polio, responding to the Ebola outbreak in the DRC, developing our influenza surveillance system across the nation. So we continue that a partnership at the scientific and public health level.
Thank you, Dr. Redfield. And so it's going to be very important not to defund the World Health Organization since it's for our national interests. And with that, I yield back.
Thank you. And last but certainly not least is Mr. O'Halloran.
And that always brings a smile to everybody's face, Mr. Chairman. Members of the panel, thank you for being here today. I'm going to start out with a forest fire. I've been to 3 of them last week because my district has 8 going on right now. And when I get to an incident control meeting, the commander of that incident control team is there, and then the division managers for that fire are all there too, or on the phone, and being able to address the issues, as are all the community organizations, police, fire, emergency response groups. They're all on those meetings, and there's multiple meetings during the course of the week with the citizens of those communities at risk. And now I'm in a process where I'm trying to figure out how this whole process is working from the standpoint of, we're here now, what's happened, we can't change that. But going forward, how are we going to address that we have enough of the testing equipment and the tracing equipment in order to address the issues potentially in October, November, and into the winter? How are we going to, or will we have, a command and control system that doesn't include 50 people doing whatever they want to do and not any ability to react to hotspots as they occur as quickly as they should maybe? And are we going to be ready? Hotspots. I have, Navajo is my district. I have a White Mountain Apache in my district. White Mountain Apache, over 1,500 have gotten the virus. That's out of 12,000 people. Navajo, the whole nation knows what happened on Navajo. It took us weeks to get enough help up there to be able to address that problem. And White Mountain Apache are still calling me all the time saying, where is this and where is that? So it's obvious that we have a shortage right now. How can we be guaranteed that we're going to have the necessary equipment and materials to be able to address it coming up during a flu season and the pandemic at the same time? And then transparency and accountability. I don't know how right now you trace a transparency and accountability in this system, because it's almost impossible. Because nobody says, that was my fault. So, and I think every one of your groups has done an outstanding job. I just can't find out what you're doing on a regular basis. I hear something on the news, but that doesn't mean that I really end up knowing what it is. And so Dr. Fauci, could you explain to me where we are at now and how are we going to attack these hotspots and address all the issues I just talked about by the fall, and will we be prepared? And I guess most of all is the entire process of how do we educate the public that has different ideas and concepts right now to be able to understand the complicated nature that all of you have addressed here today and the overwhelming need to cooperate with one another as America always has. Dr. Fauci?
You asked a lot there. I'll try to be succinct in my answer. So where we are now, as I mentioned a little bit ago, that it really is a mixed bag. It's a big country, it's very heterogeneous, and you can't have essentially a unidimensional approach to the difference between Arizona and the things you're responsible for and New York City metropolitan area. Some areas have done very well, are well controlled. They're going through the guidelines to open America. Others that we've discussed in detail today are doing poorly, and we're very concerned about them. So you're talking about, what about as we get into the fall and the winter? The first thing that we would need to do is to try as best as possible to get the complete outbreak under control so that everything is at such a low level that when there are cases that come up, you can contain them as opposed to mitigating, where you're essentially chasing after a forest fire that you just mentioned. Hopefully, we'll get that under control soon. The other thing we need to do is to get the material, which we are doing, and Admiral Giroir, I'm sure, will comment on that because he's done a phenomenal job of doing that. Getting the PPE, getting the ventilators, getting the equipment that we need, and have them in store so that if, and I hope it's if and not when, but if we ever need them, we'll have them and not be in the situation that we were in February and March.
Will we have them by October and November?
Yeah, I believe we will. We certainly will have the testing that we did not have early on. We will have it by October. With regard to the other things, the PPEs and the others, perhaps Admiral Giroir can help you with that.
Thank you again, and again, this is what we spend all our time working on under the cooperation with Department of Defense, FEMA, HHS. We've already talked about testing, and if you want a person with accountability, it's me. If we don't have it, you look at me, it's my problem. But the whole testing infrastructure is really working together. The laboratory supplies, the laboratory testing, the NIH program, the BARDA program is all working in synergy, and I'm coordinating all that to make sure it happens. In terms of PPE, we had a long way to go because almost nothing was made in the United States. I mean, literally, almost nothing was made in the United States. I mentioned earlier that a good example would be the N95 masks, and Admiral Polubchek tells me as a result of everything, we're going to have about 180 million per month made in the United States by the fall. That's ramping up very quickly, so we feel pretty good about that. And ventilators were just a good success story. I worked a lot on the ventilator problem early on. I'm an intensive care physician. That's probably the only thing I do best is work with children on ventilators. But we were very concerned about that, and by July, we'll have about 50,000 in the stockpile. We only had 19,000 to begin with, but we'll have 50,000. So we know we're going to be in good shape for that. And I'm going to use a word of Dr. Fauci. I'm cautiously optimistic, but I am very cautious, and I still don't sleep well at night because we have a long way to go. And I just want to make the point that everyone has made. It's not like this is all going to happen to us. The American people have a lot to say about this, and we want to emphasize following the guidelines, following the phases, avoiding mass gatherings, wearing these things, using hand hygiene. We have a lot to say about where this is going to go, but we all need to continue to work together to make that happen.
Thank you, Admiral. And I yield.
Thank you. Let me thank all of you for bearing with us for 6 hours, I guess, and a really thorough analysis of what is going on. So I want to emphasize again, we really appreciate your being here and your thoughtful responses to everything. Thank you so much. And I'm going to let you go because I have a long list here of documents to read for the record, so you don't have to stay for that, but thank you again. I want to remind members that pursuant to committee rules, they have 10 business days to submit additional questions for the record to be answered by the witnesses who have appeared, and I ask each witness to respond promptly to any such questions that you may receive. And we would like to insert in the record by unanimous consent the following documents: a letter from the American Society of Microbiology to the committee dated June 23rd, 2020, a letter from the Alzheimer's Association to the committee dated June 23rd, 2020, a letter from AFSCME to the chairman dated June 23rd, 2020, a letter from the American Society of Hermatology dated June 23rd, 2020, graph from Representative Olson on COVID-19 cases in the Houston area, a statement from Representative Burgess dated June 23rd, 2020, and a letter from Ranking Member Walden on Committee Rule 9B1 dated June 23rd, 2020. And I'll repeat again that any member that wishes to submit a opening statement for the record is certainly encouraged to do so. And with that, at this time, the committee is adjourned. Thank you to everyone. Thanks so much.